Hi, Taylor. Welcome. Good evening, everyone. Give me a green check if you can hear me. Awesome. Okay. Well, it looks like we only have about half of us here. Let's see. Okay, Carrie's with Sarah. Welcome. Hi, Carrie. Okay, well, we have a majority of us, so we're going to move on. Couple announcements. The quiz should be closed by now. Your test on this last unit of material, it does not include endo, should come live on Saturday morning, and you'll have until Thursday to take it. One thing that I wanted to say is because our patients are needing so much restorative work and we've not been able to get in any more new patients, we are going to, I'm going to need you guys to go ahead and take x-rays on the mannequins again. I just don't want you guys going, 3 or 4 months without taking a full mouth or bite wing or pano. So if you haven't been able to do those films on a live patient this semester, so check Blackboard, I'd like for you to go ahead and take them on a mannequin when you don't have a patient in clinic. We have those newer mannequins, and we'll be using those. Okay? Alrighty. I'm glad you like that idea, Danielle. And those mannequins are there, guys. So if there's any skill that you feel like you want to work on, feel free to say, look, I'm going to pull it out and I'm going to review that. That's what they're there for. We are really coming down the home stretch. We only have a couple weeks of clinic left. It's hard to believe that it's wrapping up so quickly. So I really need you guys to check the grade book. Make sure that I have everything posted that you have grade sheets back for. If something is missing, just bring me that grade sheet and show me, and I'll get it filled back in. Sometimes, I know last year with Blackboard, there was one particular student, I swear to you, I would enter her grades and it would delete hers for some reason. So just keep an eye on that. Check that and bring anything to me that you might have. Okay? Alrighty. Well, tonight is my last lecture, and I am so relieved. You guys can give me icons or something to let me know that you're out there. It'll probably be rather short. It is going to be on endo and endodontics. Primarily, we talk about endo being root canals, but really it encompasses the prevention, the diagnosis, and treatment of the dental pulp, so that's the nerve of the tooth, as well as the tissues that are around the root. That's what that word periradicular means. So the most common thing that you're going to see with endo is root canal therapy, okay? But there are additional endodontic procedures. Those would include pulp capping. We have a direct pulp cap, and then we have an indirect pulp cap. And all pulp capping is putting a medicament, so a eugenol-based medicine, Di-Cal, which is the calcium hydroxide, laying that down on the floor of the pulp. So with a direct pulp cap, that means that during the procedure, we actually perforated the tissue and we exposed the nerve, okay? Or it could be that the decay is so severe that it's down into the nerve. And rather than taking out all the pulpal tissue, we just put some medicine on top of it and then fill it. An indirect pulp cap is where we put that medicine in there on the base of the pulp chamber, but it's almost exposed, but it's not completely exposed. Does that make sense to everybody? Give me a green check if those two procedures make sense to you. pulp caps are not root canals. Okay, so I have no problem explaining it one more time. A direct pulp cap is when either during the procedure, when the doctor was drilling and preparing the tooth, the decay may have been deeper, or the patient jerked, or whatever it might be. And at that time, the root or the nerve of the tooth then becomes exposed. Okay? Now, we decide we're not going to do a root canal, but we're going to do a direct pulp cap. So the root has been, or the nerve has been exposed, the pulpal chamber has been exposed, and we're just putting medicine right on top of it before we fill it. An indirect pulp cap is where either the decay is deep or the filling prep is very deep, and we can almost see that pulp tissue, but we haven't perforated it. We're just going to put that medicine on top of the pulp chamber and then fill it. So that's the difference between the direct and indirect. That medicine that I'm referencing, it can be different things. Most commonly used is dical, calcium hydroxide. And does anybody remember why we use the calcium hydroxide more than anything else for something like that? I'm turning off my mic so someone else can pipe in. Okay, guys, you need to refresh on this stuff. Calcium hydroxide stimulates reparative dentin. That's why that would be the medicine or the material of choice. So think back to your DNA 110. We taught you all that stuff for a reason, okay? Then another endodontic procedure is an incise and drain. So sometimes the tissue will get abscessed, and so it just means that a big cyst forms in the bone or periradicular space. And sometimes what has to happen is we have to cut that tissue open and let the pus come out. The body sometimes will make its own little drainage tube, but other times it will not. My experience was that when my tooth abscessed, it did not create its own drainage. And so my palate swelled immensely, probably about the size of a baseball. I could hardly talk. And it was awful. And so I had to go in, and all they did was they cut the tissue and just let it drain out. It was really gross and ugh. But sometimes we need to do that. An apicoectomy, this is a procedure where we go in, you flap back the tissue, and you cut off in a kind of crescent shape the tip of the root, okay, the apex of the root. Then we have what's called apical curettage. Sometimes, again, I had this procedure done when you've had a really big cyst from an abscess. Then what happens is even though you go and you do an incise and drain and you do the root canal on the tooth, it continues to flare up. And the apical curettage is just where we go in, we flap around the apex of the tooth, and then you take that surgical spoon and surgical curette and you clean out the tissues, because what has happened is all that bacteria, you clean it out of the root and the nerve canal, but again, it's abscessed and it's gone into that bony space, into that cyst area. And so apical curettage is just cleaning all of that out, okay? And then we have what's called a retrograde restoration. So sometimes when we've done root canal therapy, we'll try to take care of it, you know, from the incisal aspect of the tooth. A retrograde restoration is where we need to go in from the apex and try to treat it in a reverse way. So we treat it from the apex going down towards the incisal edge. And again, that's typically a retreatment procedure after we've attempted to do root canals once or twice. That is an option. Another thing that you might see the endodontist do is a root amputation. So on multi-rooted teeth, in an effort to save the tooth, there may be one canal that we just can't get to calm down. And so what we can do is go in and cut off that root. So on a mandibular tooth, it might be the mesial or distal root. On a maxillary, remember it could be the mesial buccal, distal buccal, or the lingual root. Okay, so again, knowing your tooth structures and root anatomy from DNA 103 is going to be really helpful to you in endodontics. The office typically looks like a typical dental office or operatory. Now we do have Dr. Pagan's office that you guys are all rotating from and his office is pretty high-tech. So along with the specialty equipment that your book talks about, like having apex locators, extra ice, handheld devices that help with that sort of thing, we also have a microscope that just makes everything, magnifies everything so that he can really work and make the smallest incision possible in the tooth, but yet it's large while he's working. So really nice technology. Also, you'll find that Dr. Pagan was the first in our area to have the cone beam technology, and that's basically, it's kind of like a CAT scan. Dr. Culberson now has one, but what that does is it gives us a three-dimensional view, because if you remember from radiology with Ms. Thomas, our images end up being one-dimensional. So with those cone beam technologies, we can start to have three-dimensional images. And that's very helpful in endodontics, because remember we talked about sometimes teeth can have accessory canals and extra canals. So if you can turn that image and manipulate it, you can look at it from different angles and make sure that you're not missing anything. Does that make sense to everybody? Give me a green check if you're good with that basic understanding of the procedures and what the office looks like. Great. Okay. I'll clear you guys. Okay, so you've seen this slide like 7 times now, who the team is when we talk about specialties. Okay, we have the patient, and typically the patient comes to us with a chief complaint. That's what that CC means. And they'll say, oh, my tooth hurts when I bite on it, or they might say it's sensitive to both hot and cold. Okay, that's a key factor. Just being sensitive to cold typically isn't a diagnostic type factor that we look at. We want to know if it's sensitive to hot and cold. We look for facial swelling or any sort of swelling of the tissues. And many times the patients will complain of throbbing and or a constant pain. It'll wake them up at night. You know, they can tell a difference in atmospheric pressure. So like this time of year, we can really tell it if a patient is in the house and they walk outside, and as they walk outside, it starts to throb on them, okay? We typically have a referring dentist, which can be the general dentist or prosthodontist. Sometimes, you know, even other specialists who are treating the patient may end up seeing things. Then we have the endodontist, and they will make the diagnosis. Is it reversible or irreversible pulpitis? If it's reversible pulpitis, that means that the tooth will calm down eventually, and root canal is probably not needed. If it's irreversible pulpitis, it means it's just inflamed, it's infected, it's done, okay? And that is the diagnosis that will typically get us the root canal. Other things include perio abscesses or acute periradicular abscesses, okay? Again, all things that the specialist makes the diagnosis of and is looking for. Many times we'll have a surgical assistant in with endo as well, just depending on the procedure that is being done. So again, they specialize in patient assessment and monitoring, the specialty instruments, having that advanced aseptic technique. So tell me, with endo, do we have bone exposure? I'm going to turn off my mic so one of you can chime in. Okay, I don't know if you want to run the audio wizard. Did anybody else hear the question? In endodontics, do we have bone exposure? Can I have a green check if you guys can hear me now? Okay, so it looks like only 4 of you can hear me.
Isn't it that only the nurse are? Yes, I don't know. Well,
yes, Sarah, I'm sorry. I just caught the tail end of it. Sarah Bryson says yes. Sarah, Pfeiffer, and Carrie, can you guys, I'm going to mute myself. If you guys can go ahead and repeat your comment.
we both said yes.
Absolutely, there is bone exposure. When we're doing endodontic therapy, unless it's a direct or indirect pulp capping, we're going to have bone exposed. So again, all of those aseptic techniques that we've talked about, sterile water and that sort of thing, all of that's going to be very important even in endo, because your bone exposure is from the inside of the tooth. If you think about, if you clean out all of the nerve tissue, then the bone is exposed, right? At the apex of the tooth. Go back and look at some pictures of the teeth. If you were to pull out all the nerve supply and all of that pulpal tissue that's in there, that hole that all that nerve tissue and blood supply comes into the tooth with, that hole's going to be empty. And at the bottom of that hole is bone. So absolutely. So that's why that aseptic technique is so important. Again, we're going to look at procedures for controlling pain and patient management. As well, we have that office manager and billing specialist. Our instruments and supplies, we're going to have a lot of radiographs. You're going to have pre-op radiographs, periapicals. The doctors are going to need these to be very accurate. They need to be able to see the apex of the tooth. And throughout the procedure, you may take multiple radiographs so that they'll leave the files in the tooth and have you take an x-ray so they can see working length. They can make sure that they're getting down there. You've got your mirror and explorer, okay, and your anesthesia. You use an endodontic explorer. It's much thinner and longer. It helps to identify the canals. We use a Gates Glidden burr. Your book has some really nice pictures of that. That attaches to the slow speed handpiece. We have an endodontic spoon excavator. We have a root canal sealer. We'll use spreaders and pluggers, a Glick #1, paper points, files, and brooches, okay? So you're going to need to spend a little bit of time learning the files and brooches. everything, all of the endodontic instruments, they're longer because remember, they have to get to the apex of the tooth. So they're going to be a lot longer than your regular restorative instruments. You're going to, when you set up for this, you're going to have your restorative cassette along with your endo cassette. All right, so going into these files and brooches, they are made of nickel titanium. So I want you to think back to ortho. Why do we use nickel titanium? And I'd like to hear from Brittany. Try one more time for us, Brittany. I wasn't able to hear you. I heard you come on, but then I couldn't hear your voice. Okay, so Brittany's having some mic issues. But let's go to Danielle. Danielle, why do you think we would use nickel titanium? Okay, Taylor.
I honestly don't know why they would use that, to be honest.
Okay. Good. Sarah Pfeiffer texted it in for us. Thank you, Sarah and Carrie. Because it doesn't rust and it's very strong. It's very strong. Remember, nickel titanium, while it's flexible, it's still very strong, okay? And those files and brooches, when you look at them, they are really thin, but they have a really big, tough job to do. So we need them to be strong for the job that they're made for. They are color-coded by length, so you'll find that everything is color-coded by length and diameter, okay? Really, that should be they're color-coded by diameter. If you look in your book, they have a really nice chart on that. Your K files, your headstrom files, they're used for cleaning out the canal, shaping the canal, and widening the canal, okay? The reamers and brooches, again, are used for cleaning out the canal. The brooches are different from the files in that the brooches, what does K stand for? I have no idea, sweetie. It's just what they are. Good question, though. The brooches actually have like fish hook projections on them. K files, headstrom files, and reamers, they can be reused as long as they're not bent too much, okay? Brooches, however, get pulled, thrown away after each use. They'll be disposed of in the sharps container. So please correct your slide and know that they're color-coded by diameter, that second bullet there. Now, you're going to have different things that will help you measure. When they look at the radiograph, they're going to say, okay, it's, 10 millimeters, okay? So what you're going to do is you're going to use a rubber stop on the files and brooches at 10 millimeters. And when you pull out the kit and you look at this, you'll see we have a little thing that helps you measure them. Your book has some really good pictures as well. And you just put that rubber stop there so that way you cannot go any further than, say, that 10 millimeters. Does that make sense to everybody? So I like to think of the brooches kind of like the pulpal tissue. Think about like an orange, okay, the inside of an orange. You know how when you peel the orange, you still sometimes have that white, I don't even know what it is, but it's that white netty type of fleshy type meat, okay, between your orange and your peel. okay? And so the tooth is very similar. So we have nice, soft pulpal material that's decayed, okay? And that's real easy to get out. But connected to those walls is kind of like that fleshy type consistency. And so the broaches are really nice. The broaches work on both the push and pull, okay, because of those fish hook projections. And then the files only work on the pull stroke. We want to keep the canal, we want to get the canal clean, but we don't want to make the canals too wide. Can anybody guess why we wouldn't want to make the canals bigger than they need to be?
Can that interfere with the teeth adjacent to that tooth?
Sometimes we can have abscesses that kind of spread, but the purpose of trying to keep the canal as small as possible is because we're taking out all of the vital tissue. And so when we take out the vital tissue, the tooth is then kind of like an eggshell, okay? It's hollow. And so if you think about an eggshell that we only take out, think about if you were to boil an egg, okay? And you were able to drill down into that boiled egg and you were able to take out just the yellow yolk, okay? Think about how much stronger that would be with the egg white still in there, okay? Where if we compared to if we took our boiled egg and we took out the egg whites and the yolk, all we have left is the shell. Does that make sense to everybody? So we could crush that egg shell a whole lot easier without the egg white in it versus the eggshell that has it in it. Does that make sense to everybody? Give me a green check. Only give me a green check, though, if it makes sense. Okay, that only makes sense to a couple of you. Okay, so here's another thought process. Think about a chair, okay? And you've got a chair that has 4 wooden legs, okay? We have 2 chairs. One chair has solid wooden legs. The other chair has hollow wooden legs. Do you think the chair that has the hollow wooden legs would hold the 300-pound man better than the chair with the solid legs? Danielle's going to text me. No, okay? So it's that same concept that if we can keep tooth structure there, it makes the tooth stronger. So we want those canals, while we've got to clean out all the infection and all the tissue that's in there, we definitely want to save as much tooth structure as possible. That's why Dr. Pagan works under the microscope, so that way he doesn't have to wait to what he can see with his naked eye. He has magnification there. Does that make sense now? Better sense to everybody? If I could get a little bit of feedback, I'd appreciate it. Okay, so now a little bit about half of you it's making some sense. Okay. All right. So the actual root canal procedure, because this is the bulk of endodontics. So we're going to talk about this procedure. First thing they're going to do is to have that pre-op radiograph, and we're going to estimate the canal length. Then what they're going to do is go in with a drill, typically a high speed until they reach the pulp tissue, and then they're going to use the slow speed. And why do we use the slow speed? Anybody could jump in. Why would we want to use the slow speed when we're dealing with pulpal tissue? Thank you, Miss Bryson. That's right. The pulpal tissue is softer. So we don't want to slice through it like butter, right? We want to be able to control what we're doing. So if we go slower, we have a little more control. Good. So we're going to open the tooth, and at that point they're going to expose the nerve, and that's just the pulpal tissue. They're going to remove the nerve tissue. They can use the Gates-Glidden burr to remove the tissue. They can use those brooches and the files, okay? And then they're going to clean and shape the canal. And they clean the canal with the files and the brooches, but they also use sodium hypochlorite to clean the canal. We want to disinfect the canal and make sure that we kill any of the bacteria that's in there. And then what we're going to do is we're going to fill the canal and put a temporary on it, okay? Anybody remember what temporary material we may use? Hold on, my screen just went blank. I'm not sure what happened.
Acrylic resin.
Okay. Can you guys still hear me? Give me a green check. Okay, good. So Sarah Bryson said Cavit. Absolutely, we might use Cavit. What might be another thing? I'll turn off my mic so someone else can pipe in. Thank you, Sarah Pfeiffer. That's right, IRM, okay? Guys, I want to make sure y'all aren't having memory lapses from last semester from dental materials, because all this stuff is, stuff that we went over, and it will be stuff that's on your national board in October. So, okay, thank you very much. So we're going to go ahead and put a temporary in it. Most of the time, we'll come back a second visit. Now, I'll tell you, less and less doctors are doing a 2-appointment endo, but it is kind of the golden standard, okay? So at the second appointment, they're going to reopen the tooth. They're going to make sure that everything's healing. They're going to irrigate it again with the sodium hypochlorite, and at this time, they're going to obturate it again. And they're going to obturate it with the gutta percha. And so the gutta percha is it's a tree-based, gutta percha is actually a type of tree. I believe it comes from South America, but I could be wrong on that. But they're going to just usually put some sort of seal apex material at the base of the tooth, and then they're going to fill it with this gutta percha. And they're just little wooden points, and they do that after they've dried it out with the paper points. But they're going to place the gutta percha in there, nice and tight, seal it up, and then they're going to heat that Glick number 5, and they will sear off the top of the gutta percha. And because the gutta percha is a tree-based product, it has sap in it. So when they heat it up, and they cut it off, it releases that sap to make a nice seal, and it's organic, okay? Being that it's organic, the body will be accepting to it. And then typically, the patient is referred back to their general dentist to restore the tooth. Now, depending on where the tooth is at, will be depending upon how they restore it. At one point, they used to say anytime a tooth has had a root canal, it needs to have a crown. But that's really not the case. We need to look at the function of the tooth. We need to look at the patient habits and that sort of thing. And so molars typically do. And anterior teeth, again, that's going to be a doctor preference. Sometimes the teeth will discolor when they've lost their vital tissue, and so that's why they put crowns on them, but you can go in and do internal bleaching. And so I encourage you guys to review your notes from DNA 110 last semester about internal bleaching and how that's done. And Danielle commented, she put a little note in here that Dr. Pagan used MTA instead of gutta percha, and she's not sure what that was. I'm not sure what it is either. Sometimes the specialists, they go to their conferences and they find newer products. So your book actually has a new edition, so I will look into that and see if the new edition says what the MTA is. And I'll email you guys that probably next week because I won't be back on campus to look at that new edition until Tuesday. Okay, so during root canal therapy, things can go wrong. And I'll tell you, I don't feel super comfortable with general dentists doing a lot of endo. And, you know, there are some who do it all the time, but I've seen anterior teeth that have pretty significant curvature of the root, and when I was on the board of dentistry, the #1 thing that I saw was problems with general dentists doing endo. There's a specialty for a reason, so I do strongly recommend that patients get referred to the specialist for any sort of endo. But again, general dentists can do it. Things that do go wrong. A perforation. A perforation is where either they take the file or broach or whatever and they go completely out of the apex of the tooth, okay? They can sometimes go out the side of the tooth because they use too much force, and instead of following the normal curvature of the anatomy, they go out the side of it. And that's what a perforation is. They can either over or under instrument, okay? So that means they clean it out too much or they don't get everything out. And so the bacteria repopulates and starts to reproduce and cause troubles. They can also overfill or underfill. So when they're filling the tooth, they can actually put so much filling material in there that it kind of pushes out at the apex. Or they can underfill where they don't get all the way to the apex. And so if you think about your blood supply, the blood is going to carry the bacteria all through the body. Well, it's still going to pass through. And if they have underfilled, meaning that they didn't get their filling material all the way to the apex, what will happen is as the blood is passing through the apex of that tooth, it can kind of come back up into the very tip of the canal. And ladies, I'm talking just microns, okay? Very, very small amount. But what can happen is that's kind of like a heart defect. You know how we talked about valvular damage in the heart and getting infections that way? Same thing happens. That bacteria kind of gets caught up on the apex there, that little area, and again, it can start to multiply and you end up with reinfection. I hope that makes sense to everybody. And then sometimes they've missed a canal. Sometimes there's just a lot of post-op pain, okay, for them to have. Sarah and Carrie, thank you so much for the feedback. I do appreciate you giving me the green checks and stuff that things are making sense. Okay. So post-op care really depends on the procedure. So most common is that they're going to kind of feel like the bone at the apex of the tooth that has had the root canal is going to feel bruised. And if you think about what they're doing with those files, taking them in and out, in and out, in and out, it produces that kind of bruised feeling. And you know, if somebody just taps you a couple times, it's fine. But if they tap you 100 times, even though the tap itself doesn't really hurt, after 100 times, you get a little bruise there and it's sensitive. So it's that sort of thing. We need to control bleeding, okay? So we're, again, using those same sutures. You've seen this part of the slide 3 different times this semester. So this should tell you that it's probably something rather important to know, okay? We need to look at swelling. So remember, even with endo, we're going to do ice 20 minutes per hour for the first 24 hours, okay? And after that, we can use warm compresses. We may need a soft diet. So if we flap the tissue, we might need them to have a really soft diet for a couple of days to a week until things reattach and all that good stuff. And again, real common for them to have bruising depending on the procedure. Sometimes we can have bruising as a result of lots of anesthesia, that sort of thing. Any questions about post-op care? Taylor's texting us something. Nope, thank you. Okay, good. All right, documentation. Again, you always want to do that medical dental history update, make sure nothing's changed. We are going to take pre and post vital signs. If we've used nitrous, we're going to use that log. Remember, we monitor. We're going to talk, list the procedure that was completed. So did we do a root canal, which you can shortcut with RCT, or did we do an apicoectomy, you know, whatever it was. What were the teeth numbers involved? Where was the area that we worked on? The anesthesia that was used? Any post-op instructions that we gave the patient, and what is their next appointment? That's what the NA means. Okay, Heather, well, we're actually almost done, so you probably will want to go ahead and watch the recorded version, okay? All right, any other questions or concerns about endo? I'm going to mute myself for a little bit.
When will this quiz be available?
Good question. There is no quiz on endo. It's included as part of the final exam. That's correct, Marissa. NA means next appointment. It could be RTO. It could be NV, next visit, return to office, anything like that. Okay, let's see here. So Taylor says, okay, no, Taylor, you do not have to do 3 bite wings, 3 panos, and 3 full mouths. It's one of each that you need to have. The only reason why the grade book says 1, 2, and 3 is because some of you have taken more than 1, and so I just have to put in additional columns. So you really need to just follow what's in the syllabus as far as requirements. So don't get confused on that. Good question. Okay. So just to recap, your test will be on this last unit of instruction that we've done. So whatever I've lectured on, I believe it's chapters 50. I can't get out of here, so bear with me. I think it's chapters 54, 55, and 56. It should be surgery, perio, implants, and endo is what covers test 2, okay? Your test is available Saturday through Thursday, okay? What's the best way to study for the test? I think the best way to study for the test is note cards. And I would look at my material and I would say, okay, what's in the book, what's in the workbook, and what's in her PowerPoint? Because if you see things in multiple places, that's usually a pretty important topic to have, okay? So I would say if you see it there. You also have the syllabus that gives you an outline of everything. If you look beyond, I believe it's beyond the schedule, you can use that outline to make your study notes, okay? Again, if I've put it in a slide, you should probably go back to the book and study that material. For the final is comprehensive. I'm going to say study the same way, okay? I'm really hoping that you guys being in the material to do your presentations will help with your final exam. as well, covering the review of restorative procedures, because there will be some of that on there. Most all of the questions I'm taking from the test bank that comes from the book. Okay. Yep. So just a mix of studying the PowerPoints in the book. Absolutely. If it's in the book and it's in the PowerPoint, I would definitely have a note card on it. Okay. I would encourage you guys to maybe have a couple study groups if you can. You know, quiz one another on different topics. Listen to and watch the videos of the clinic demos. Okay. Any key things that I say in there, that's how I would prepare for that. Next week starts your presentations on medical emergencies, and so everybody will need to have that turned in to me. I would say at least by 3 o'clock on Thursday, so that way I can get them loaded. We're going to present them as you email them to me. Back to the test. Danielle says, do you think Evolve would help? I do think it would help because, again, if they give you like sample questions and stuff like that, absolutely. Your workbook, all of that should be things that do help you with the material and learning the material. Okay. You know, you guys know what works good for you and what doesn't. So use the resources available. If things don't make sense to you, try YouTubing them. You know, if I've said something, I've referenced a procedure, it doesn't make sense to you when you read the book, you know, go to Evolve, because I think your Evolve account does have some demos, videos to watch, but also YouTube them. I mean, if you just go into YouTube and put, you know, video of root canal, University of Michigan has all kinds of stuff on YouTube, and they are really good. Okay, and then after we do the medical emergencies presentations, we'll be doing your dental theory and practice, which is basically your review of restorative. All of that is on Blackboard as far as the assignments go, so take a look at those for instructions. Any other questions or concerns? I see Taylor texting, so let's see what comes in. So when are both of those projects due again? Taylor, the medical emergencies is going to be due by like 3 o'clock next Thursday, so that way I can get them loaded in. And then the restorative presentations that you work on with your partner will be due the following Thursday. So next Thursday is the 17th and then the 24th. If we can get through everyone's presentations by the 24th, then we don't have to have class on the 30th, your last week of classes. So that would be my hope for you guys, not to belabor things, that we get things done. Any other questions or concerns? Okay, I see Danielle texting. When did you say the skill evaluations would be graded? The ones from yesterday, I'm hoping that I'll be able to get them posted tonight. If I don't get to them tonight, it'll be tomorrow, tomorrow during clinic. Okay. So not hearing any other questions or concerns, then you guys can go ahead and sign off. Thank you, guys.
Ms. Mesmer, do you remember how I told you yesterday about the quiz? I can't hear you.
Go ahead. I'm going to turn off my microphone.
I talked to Carrie about it, and Carrie had the same problem that she, I guess, clicked an answer and it did not save and showed her as like that she didn't select anything afterwards. And I'm pretty sure we even had the same questions where that happened for the quiz from, I think it was the oral surgery quiz.
Okay, let me look into it a little bit more, okay? Now that I understand what you were trying to tell me, let me go in and see if it'll show me that you marked a question or not, okay?
Because Ms. Mesmer, it was kind of just like a really easy question, so I didn't know if I should tell you about it or not. So I'm just glad Sarah sort of had the same thing, so. I don't know.
Yeah, we talked about it earlier because she told me about it and I was like, oh, I have the same problem. So yeah, so we just wanted to make you aware of it.
Thank you.
Thank you.
Which question was it? So I know, well, I'll be able to see which one you missed, but do you remember the topic?
My question was actually what surgery instruments are classified as, and critical, non-critical, or semi-critical. So I'm not really sure why it didn't save as critical.
My question was, I think it was question number 3, where it was like asking why, I think it was like why other surgeries held early, or no, what time is the best time to have the surgeries or something. And it was supposed to be like early in the morning due to them not eating and stuff, and I selected that, but it showed me afterwards that I didn't select anything.
Okay, I'll take a peek at your quizzes and see if I can come up with anything else. And I'll talk with tech services or our Blackboard administrator and see if they can, if there's another way that I can dive in even further.
Awesome, thank you.
Thank you guys so much. I don't know what I'd do without y'all in class, so I appreciate all y'all's commitment.
Don't be on the warpath tomorrow.
I won't.
We give our best to make you happy.
I know, I appreciate it. Y'all have a good night.
You too. Thank you.